Give it a moment here as people probably getting home from work or just setting up their computer to turn in today. Looks like some people are trickling in as we talk. So give it just a moment here. All right, so let's get started. Welcome to this Omega webinar. Most of you probably know who I am, but I'm Jared Jones. I'm excited today to have Margo Steinlage here with us from the Steinlage Insurance Agency, where their specialty is everything and all things Medicare. And most times when our clients are approaching Medicare age, I like to say it's way out of our depths. Medicare is so complex. You'd think it should be simple, but it's not. And we find a lot of benefit in working with Margo and her firm in helping our clients navigate that maze. So let me just quickly introduce Margo, and then I'll turn it over to her to take us through her presentation. She let me know she's more than capable to handle questions as they come in. She can see them pop up on her screen. So as we're moving through the presentation, please feel free to type any questions you might have in that Q&A box. And if you need some help, it's down at the bottom of your screen in the bar. So hopefully you can find that. And without further ado, let me just introduce Margo. So Margo Steinlage, with over 15 years of health insurance industry experience, complemented by a law degree, Margo has become nationally recognized Medicare expert. Margo's team is a trusted resource for thousands of clients and works with wealth managers like Omega, advisors, CPAs, and estate planners across the country to integrate Medicare planning into clients' retirement discussions. And Margo's mission is to maximize the Medicare experience and minimize the complexity. So without further ado, I'll turn it over to you, Margo.
Thank you very much. And thank you, Omega Wealth, for letting me be a guest speaker today or tonight. Just a little recap on Steinlage Insurance Agency and how we really can offer this white glove service to you all. How we work is when you are approaching Medicare, or if you're an early retiree, retiring at 63 or 64, we can come in and look at your entire situation. Do you need COBRA? Do you need ACA, Obamacare for a few months to float you to your Medicare eligibility? Are you working past 65? Do you need to take Medicare at 65? So our advice is really based on your entire snapshot. Do you have a younger spouse? Do you have children on your group health plan? Or do you have children that need coverage? We're not just looking at the Medicare component when we sit down and have a conversation with you. We want to make sure we're kind of tidying up any loose ends that may be affected by your 65th birthday. All of our services are free to our clients. How we get paid is a question I often get. We are receiving commissions from these insurance carriers if and when you need to move into a specific product. My team is all salaried. They are fully removed from the commission conversation and aspect. So they have no idea if plan X, Y, or Z pays Steinlage Insurance a specific amount, or if they don't pay us an amount. And so I've really prided our agency to become this fiduciary-like consulting service when it comes to Medicare, because there's so much noise, there's so much distraction with Medicare Advantage plans, with Medicare supplement plans, drug plans. What we want to relay over to our clients is accurate information, clear information, and unbiased information. So that's kind of our entire goal and agenda when we sit down with a client. And then we're very proactive with touching and outreach to our current clients when this open annual enrollment comes along every fall. So for the last 6 weeks, we have been pinging and emailing and texting our current clients to say, hey, here's what's coming down the pipeline for 2025. You've set your supplement and your drug plan or your advantage plan in the years past, but we need to make sure that it's still appropriate in the optimal plan for 2025. So we go through this very rigorous drug collection. We get your up-to-date drugs, your up-to-date up-to-date pharmacy, your income information to see if there's any need for an IRMA appeal. So we are a one-stop shop for all things Medicare, but we have a lot of these ancillary services that we offer for free. And we also have that back-end customer support if and when there's ever Medicare hiccups that surface, a billing issue, a misplaced card, a prior authorization headache or hurdle that you need assistance with. Our team can come in and advise. We are nationwide, so whether you live here in Virginia or the DMV, or you want to move down to Florida or Phoenix, we follow you. We can assist regardless of your zip code. And yes, we do have clients in Hawaii and Alaska, which is kind of cool. Okay, so today we're really going to take a high-level look at who is eligible for Medicare, and then we're going to go into detail as to who can delay Medicare, who has to enroll in Medicare at 65. And then we're going to look at what is Medicare. There's a lot of lingo and terminology that can cause confusion. What is Medicare Part A, B, C, D? How do these different parts work with original Medicare? What are the pros and cons to each different pathway that you can take under Medicare? And really define the language of Medicare. And then lastly, we're going to look at regulation changes with this Inflation Reduction Act that is coming down the pipeline in 2025. What does that mean for you as a consumer, as a beneficiary under Medicare? What's your pricing exposure? And also we're going to look at IRMA, Inflation Reduction Act, or excuse me, your IRMA surcharges for high earning individuals. So, we'll cover IRMA towards the end of the webinar. I just want to put that on your radar because I get a lot of questions around IRMA here at the beginning of the presentation. Okay, so who is eligible for Medicare? The easiest way to explain this is that as you turn 65, you need to sign up for Medicare to avoid any lifelong penalties and gaps in insurance. So the general rule is that you have to sign up for Medicare at 65 to avoid lifelong penalties and gaps in your health insurance. Like all rules, there are exceptions. The exception to the general rule that you have to take Medicare at 65 and enroll in Medicare is if you or a spouse plan to continue working and the employer is offering you group health coverage, then the size of the employer determines whether or not you can delay Medicare or you have to take Medicare. So Medicare is optional for those individuals that are working past 65 with a large employer. If you're not working with a large employer or your spouse is not working with a large employer, then you have to take Medicare to avoid any penalties. If you are working with a large employer or your spouse is working with a large employer and there's 20 or more full or part-time employees under that employer, then Medicare is optional. We can sit down with you and look, here's what your premium is on your group health plan with a large employer. Here's the deductible. Here's the max out-of-pocket exposure. How does that compare to moving into Medicare? Are you a high earner? Are you going to have income surcharges on your Medicare premiums? What's your supplement benefit look like? What's the drug plan exposure look like? Which pathway, stay on the large employer plan and delay Medicare, or move into Medicare because it makes more sense either financially or with the benefits. So we really take a deep look into delaying Medicare or stay on the group plan or make a move into Medicare at 65 if you plan to continue working with the large employer. Okay, but the takeaway here is that the general rule is that you need to move into Medicare at 65 unless you're working with a large employer. Also, if you're with a large employer, I see we have a question here, but if you're working with a large employer and you are contributing into your HSA for either yourself or the full family on the plan, then the advice we typically give is to delay both A and B to avoid any conflict with IRS so that you can continue to max out your HSA. So if you're on that large group health plan and you're contributing into an HSA, a health savings account, then typically you're delaying both A and B so you can continue on that HSA plan and max out the HSA and get the tax benefits. Okay? If you are contributing into the HSA and you plan to retire later, let's say at like age 68 or 70, when you come back to Steinlage and say, hey, I'm ready to retire, let's trigger a special enrollment period to move into Medicare at retirement, we need to connect so that we can time the stopping of your HSA contributions. There's a 6-month retroactive look back on the Part A benefit that we need to take into consideration. And our team will help you kind of tee up that HSA contribution and the stopping and the specific month and how much you can actually contribute that given year. So some planning with Omega and Steinlage is nice on our end because, hey, if you want to retire in January this upcoming year, a little bit of heads up to Steinlage is appropriate so that we can help you stop the HSA contributions. I'm in the weeds here, but I always get people attending these webinars that have that specific question. That's why I like to go into detail there. But it's revolving around a large employer's group health plan. If your employer is a small employer with fewer than 20 employees, then Medicare needs to be primary. You have to sign up for Medicare at age 65. And then the conversation shifts to how does that small group health plan with the small employer fit with Medicare as a secondary payer? Does it make sense with premiums on that small group plan to keep it? Do you have a younger spouse on the group plan, kids on the group plan, or you have Medicare as primary? Does it make more sense to move into the supplement drug plan or advantage plan pathway and look at ACA for your children or your spouse? There's no one size fits all response there, but we're asking questions. We're manipulating income, if at all possible, so that we can kind of get you the best deal and the best bang for your buck with regards to benefits. So our initial 15-minute consultation with you really goes over this, access to employer-sponsored coverage. How large is the employer? What's the premium? What's your deductible? All right, Lisa, you have a good question about federal employees. As I was telling Jared earlier, I have a really good resource, Tammy Flanagan. I sent that over to Jared. She handles the advice around federal employee health benefits and Medicare. Is it right to take Medicare Part B? Do you want to delay Medicare Part B? Do you need to take Part B? So I can't give a general rule of thumb for the federal retiree because I would want to know, and I know Tammy would want to know, what's your income? Are you getting slapped with a $600 IRMA if you take Part B and you're going to have a high income for the next 20 years? Medicare may not be that great of a deal for you with the federal employee health benefit. But I refer all of my federal retiree prospects or referrals to Tammy. Okay, so what is Medicare? So when you're ready to move into Medicare, whether you're required to at 65 because you're on a small employer group health plan, or you're on ACA, or you retired early, you're on COBRA, and now you have to move to Medicare at 65. When we help you sign up for Part A and Part B, and you get your red, white, and blue card, what does that give you? Or if you're coming off the large group plan at 70 because you're retiring, we enroll you in Medicare. what does that red, white, and blue card mean and provide? So everybody will have a Part A and Part B benefit once you're fully in Medicare. So your red, white, and blue card will say Part A hospital coverage and Part B medical coverage. Most of us will get that Part A hospital benefit for $0 per month. It's a free benefit because you or your spouse, you can piggyback on work history, you too, or yourself, you've earned a 0 premium because you have 40 quarters, which equates to 10 years worth of work history. So 0 premium for the Part A benefit. Part B medical of Medicare has a standard Part B premium of $174.70 per month. And this is adjusted every year based on Centers of Medicare. They usually announce it in mid-November, and you'll see the adjusted rate take effect on January 1st. So for this year, it's $174 per month. The IRMA, or the income surcharge, will be added if you are deemed a high earner under Medicare's eyes, which just for right now, it's $206,000 in modified AGI or $103,000 in modified AGI for a single tax filer, $206,000 for a joint tax filer. If your income, your modified AGI is above those figures, then you will see a higher Part B premium than the standard 174. And I'll show you the bracket towards the end of the seminar, but I just want to plant that seed in your mind because we are looking at that IRMA when we're making recommendations, whether staying on the large employer coverage or showcasing what your true out-of-pocket exposure is when you do make that move to Medicare. The IRMA really comes into play, especially if you are in the upper $300,000, $400,000, $500,000 modified AGI. So you will pay for Medicare. Medicare is not free. You'd be shocked by how many people think Medicare is free. But everybody will pay for the Medicare Part B premium. Some may pay more if they're a high earner. Now, you walk in the hospital, I always say you get hit by the bus and you go into the hospital and you're in the hospital for, 3 weeks or 3 days, and then you have follow-up treatment for the next 6 months. You have PT, OT, you get MRIs, you may get some x-rays, and then you're going to see your orthopedic surgeon, okay? You have $100,000 worth of medical bills. When you show your Medicare card and you go in the hospital, you will have a $1,600 hospital deductible per 60-day occurrence. So if you go in the hospital in January and then in June you go back in the hospital for COVID, this resets your Part A deductible. If you go in to see your doctors, your MRIs, your PT, you are triggering the annual Part B medical deductible, which is $240 per year. Okay. Once you satisfy the deductible, you're looking at Medicare covering 80%. You're responsible for that 20% remaining coinsurance. There is no cap or ceiling on your 20%. So your deductible exposure and that 20% coinsurance, plus you'll see here, there's no drug coverage, there's no dental, there's no vision. All of these gaps are where the ancillary products come into play. Your Medicare supplement, your drug plans, your Advantage plans. All right, so Medicare alone has significant gaps. How do we fill these gaps? And really, there's 2 pathways, and this is your initial decision-making process. Which pathway do you want to take as you approach this Medicare transition? Our team has helped you decide that, hey, I can delay Medicare for a few years and stay on my large group plan, but now I'm retiring and I have to come off. Our team has said, hey, you're on Obamacare or ACA plan coverage. You have to move into Medicare at 65. We've helped you enroll in Medicare. Now, which direction do you want to opt for? Do you want original Medicare with a supplement and a standalone drug plan? That's the left side of this screen. Or do you want to go with what's called Part C, Medicare Advantage Plan? It's important to note that no matter which route you take, you will still be responsible for paying that Part B premium, the $174 per month, plus any income surcharge. Okay, there's really no wiggle room around that standard Part B premium. So regardless of your decision, you're still paying that Part B premium. And here you can only go one route or the other. You can't have Medicare supplement and a drug plan with an Advantage plan. So an initial decision is required here. And our goal is to educate you on kind of all of the pros and cons to either pathway so that you're making a very informed decision. You know, buyer beware, do your education and due diligence, because what I always tell clients is your initial decision here can have long-term consequences. And I will, you know, hone in on those long-term consequences tonight, but it's important to do your due diligence here. Make sure you're working with a company that works on both sides of the equation here. So let's look at the pros and cons of Medicare with a supplement and drug plan pathway, which is this screen right here. When you opt for original Medicare with a secondary supplement, also known as Medigap policy, you can go to any doctor that takes Medicare. Medicare, or traditional Medicare, is your primary payer. The question you will always ask providers is, do you take Medicare? You will never ask, do you take my AARP United Healthcare supplement or my Blue Cross Blue Shield Anthem or Care First supplement? You never ask that question when you have this level of coverage. The question to ask is, do you take traditional or original Medicare? When you go to a provider, you show your Medicare card and your supplement card. Provider bills Medicare, Medicare turns around and submits the claim to the supplement carrier. Within the supplement market, you have Plan G, Plan N. These are two types of supplement products that come in and fill the gaps of original Medicare. So let's say you choose a supplement G with original Medicare and you get hit by the bus. You're in the hospital for weeks. You have the follow-up treatment for 6 months. $100,000 worth of medical bills that are being, accumulated. When you show your Medicare card and the supplement G card, regardless of the carrier, that provider, the hospital and the medical providers, will bill Medicare. Medicare will pay its portion and submit the residual to that supplement G carrier, regardless of who that carrier is. With that level of coverage, Medicare plus supplement G, your only out-of-pocket exposure is the Part B medical deductible of $240 per year. So it's excellent coverage. Your supplement is filling all of the gaps in original Medicare. It's paying the $1,600 hospital deductible. It's paying the remaining 20%. The only responsibility you have is the $240 deductible. Now, you'll also need to add a standalone prescription drug plan. And this is where we have about 20 to 30 plans per year, depending on the year. Next year, we're going to see a lot of consolidation within the Part D drug market because of the Inflation Reduction Act. A perfect example, Aetna had 3 policies available for clients this year. Next year, they're consolidating that to 1. Okay, so a lot of movement in volatility this year because of that Inflation Reduction Act. When you're new to Medicare, we will set you up with a drug plan, Part D drug plan, even if you're not on any prescriptions, because Medicare will penalize you if you opt out of Part D. They subtly force you into the drug plan market, regardless of how many prescriptions you're on, by slapping a penalty on if you opt out of Part D. So get the cheapest drug plan in that scenario. If you're on no meds, cheapest drug plan is usually about, $5 a month on average. Depending on your list of prescriptions, we will look at, your dosage, the frequency, your preferred pharmacy. If you're in McLean, do you like Preston's Pharmacy, or do you like, Harris Teeter, Costco? We are looking at deductible exposure, tier 3, tier 4 copay levels. Who's giving you the best total cost based on many factors, not just premium? And we are giving you, 2, 3 options here to say, hey, based on all of these different factors, here's the top 3 plans for you for this year. Our recommendation will likely change next year because of the market changes, your prescription changes, or the pharmacy manufacturer discount changes. Okay, a lot of volatility in that drug plan market. Highly recommend a review. Your broker should be proactively reviewing this specific drug plan portion for you each and every year. That's where the most money can be saved, and the most headache is usually surfacing. Okay, if you wanted dental and vision coverage, you would also add a standalone dental and vision plan. Here we're asking for your preferred dentist. Do they accept dental plans? Are they only in network with PPO plans? Do they bill PPO plans? So we're asking a lot of questions to get you the optimal dental plan as well. When you are new to Medicare, you're turning 65 and you're needing to enroll in Medicare, or you're coming off your group health plan, your large employer sponsored health plan, and you're moving into Medicare after 65 when you decide to retire. You are new to Medicare. You get a 6-month window to sign up for your supplement plan without any health questions. Okay. Outside of that 6-month window, you have to answer health questions, pass medical underwriting to get approved by your supplement carrier. So you have this unique sweet spot to sign up for the supplement and time it with your Medicare start date. You don't want to delay that process. Otherwise, you run the risk of being locked out of a supplement program if you fall on the outside of that 6-month window. 99% of clients will set up Medicare, set up their supplement and drug plan all in the same month. I rarely do I recommend doing anything different than that. So no health questions when you're initially getting into the system. Now, a prickly situation can unfold if you're with the wrong supplement. You went with a very small carrier because they flushed the market with cheap rates. And now 3 years later, they're jacking up the premium and you just experienced a 23% increase. When you want to, which is no fun, when you want to rate shop these plans, supplement to supplement, supplement G to supplement N, supplement G with United Healthcare to supplement G with Aetna or Mutual of Omaha, whoever the carrier is. You have to answer health questions when you make a move outside of that 6-month window. And again, your initial decision of which supplement carrier do you want to enroll in when you first become eligible for Medicare is critical. All right, so we want to look at how is your supplement rated? What's their market share? Again, do they have 25% market share or 0.2% market share? We want a stable company here. And I will say the average rate in the past of rate increases, because all of your supplements will increase every year. Run if somebody says your supplement will never rate increase. It's an outright lie. The average rate is 3 to 7%. That's been the historical increase. However, in the last 2 years, we have seen a higher than normal average increase across the board, across all 50 states, because of this rush to get services performed post-COVID. So these supplements are paying out more claims, and they're offsetting those claim payouts with higher than normal rate increases. So I would say the average rate increase for the last 2 years has been more like 10 to 13% across the board. I don't see that trending in the opposite direction. So what we're seeing, anyone who's kind of on the fence of this Medicare supplement product versus Medicare Advantage, it may be the push over to the Advantage side that a client may need with those higher than normal rate increases. So this is one level of coverage. This is the Cadillac pathway that you can choose. We look at all of these different supplement products to help you kind of narrow down the right fit based on your age, your smoking status. Do you get spousal discounts, your zip code? And then the drug plan will help you select a drug plan every year based on your specific medications and preferred pharmacies. The alternative pathway is called Medicare Advantage. So the positive over here is that you're paying up front in premiums, knowing that when and if you use care, you're taken care of almost at 100% when it comes to your medical exposure. And there's no network or restrictions on your level of care. The alternative pathway is Medicare Advantage. These are 0 premium per month. You get a 0 premium HMO or PPO Part C Medicare Advantage plan. You pay very little upfront in monthly premium, but on the back end, when you go to a networked doctor, you pay service fees, co-pays, co-insurance for every single service rendered. As you use your care, you pay $100 for an ER visit, $300 for a hospital copay, 20% for a chemotherapy medication. All of your services are being added up every year. Once you come out of pocket in copays and coinsurance and meet your plan's max out of pocket, which in this area ranges about $5,000 to $10,000 per year per person. Once you come out of pocket in those copay amounts and they reach $5,000 to $10,000, then your HMO or PPO Medicare Advantage plan will pay 100% for the rest of the year on medical and hospital expenses. So the positive here is that it's 0 premium. It's affordable for a large percentage of the population, or somebody who says, hey, Margo, I'm super healthy. I hate seeing the doctor. I never see the doctor. I swear I'll never take medicines or go see the doctor. Whatever the reason is, some people love these Advantage plans. However, there is a ugly underbelly to the Advantage product, and that comes with network restrictions, prior authorizations, restrictions in skilled nursing facilities, where if you become unhealthy, that's where the headaches and the push-pull and the red tape can come into play. That makes this supplement product much more attractive for some individuals. I don't want any restrictions on my care. I don't want a network. I don't want somebody or a carrier managing my care. I want total flexibility and autonomy. Then that supplement pathway is going to be for you. With the Advantage pathway, you're playing by the rules of your Advantage plan carrier that you choose each and every year. The perk to this 0 premium plan, again, it's cheaper. It includes drug coverage built in. It includes dental. It includes your hospital, your medical, over-the-counter discounts. There's a lot of extra perks built into these plans. The negative is that you got to play by those rules of the managed care facility or the managed care organization. I see we have a question here, so let me just. Correct. So if I had to reread that, Lisa. So if you use a lot of care, you have chronic care issues. She termed it power user of medical services. That made me laugh. Then yes, a supplemental product is going to be a better product for you because you have very little out-of-pocket exposure. There's no push-pull, no restriction, no referrals requirements, etc. Also, if you use a lot of care or you come into Medicare knowing that you have these chronic care needs, remember that initial decision-making process is important because if you are unhealthy and you go Medicare Advantage and later want to move over to the supplement 2 years down the road, the supplements are going to ask you health questions and they're going to say, hey, you have chronic care needs. You're unhealthy in our eyes. You have a high health risk. You're locked out of the supplement. The supplement market is like the only market in health insurance to date that can still request and require underwriting. And that's because they don't receive federal funding. It's all funded by people paying premiums. So they want to keep a healthy risk pool. State law requires them to give the 6-month window, no underwriting when you're 6 months around your new to Medicare start date. Outside of that, they restrict you by requiring underwriting. If you're high health risk, you're going to taint their pool, their population pool. They're going to deny you, and that leaves you stuck in this Medicare Advantage product until you become healthy in the eyes of the supplement carrier. You can shop these Advantage plans, PPO to HMO, Kaiser to Humana to Anthem, and you can bounce around on this right side of the screen in the Advantage plan market very easily. And that's what people do during the open enrollment period, October through December, once you're on Medicare. The same goes for the drug plans. You can bounce around drug plan to drug plan and shop every year, October through December. But the supplements, to move and go lateral supplement to supplement or move Advantage over to supplement, requires the underwriting. And that's where you can get locked out of a specific carrier based on your health risk. Anyone who sets a supplement up initially and later wants to move to an Advantage plan because maybe their income changes, or they say, you know what, I'm sick of paying $200 a month. That's $2,400 a year times 12 years. I'd rather keep that money. Or I have an HSA. I'll just self-insure some of my max out of pocket. You can very easily go Advantage. There's no underwriting because they're federally funded. Okay. I would say most people in the DMV and who are working with kind of wealth managers tend to go the supplemental pathway, 80% in this area. However, the national average is climbing in favor of the Medicare Advantage enrollments. And it's cheaper for Medicare if you go Advantage because Medicare no longer is the primary payer. They are subsidizing this third-party Advantage plan to pay for your care. And the Advantage plans, because they're network, they're squeezing the care for as much profit that they can get. They can do it more efficiently. So there is some like subtle incentive for Medicare to have you go Medicare Advantage. But if you want long-term success, zero headache, the supplement is generally the path. But again, I can't give one-sided advice here. I can't give advice that is right for all of you. It's very specific to personal preferences and healthcare needs. Okay, I think we had one more question pop up. I'm trying to get it. There we go. Yep, great question, Sean. What if you get a supplement in one state and then move to another state? Will they need to assess health, or does a move not reset that requirement? Great question. No, so you set a supplement plan in Virginia and you move to Florida. That supplement will follow you all across the country. You will not have to do any medical underwriting. The supplements will cover you for life. They're guaranteed issue for life, unless you stop paying premiums. I will say though, when you make a move to a new state, typically the new state will set the premium on that supplement. So if you have United Healthcare here in Virginia and you move to Florida, Florida across the board has about $100 to $120 higher premium per month. So $120 would be your premium here in Virginia. It would be about $220 in Florida when you do make that move. But there's no health questions when you do make the move. That supplement will follow you. So it may behoove you to underwrite to a more competitive plan when you make the move, if you can. But if you can't, you're still protected in the same supplement, just a higher premium, depending on the state you move to. If you move to Tennessee, I think they're about comparable to Virginia rates. Maryland is about $30 more per month on average than Virginia. That's why I live in Virginia. Okay. Once you're on Medicare, then this October through December timeframe applies to you. If you're not on Medicare, ignore it. It doesn't apply to you. When you're new to Medicare, you're turning 65 in 2025. I recommend starting this consultation. Hopefully you choose Steinlage to, handle this entire transition. But once you are kind of in that 6 to 12 month window, you just turned 64. I highly recommend jumping on a consultation, getting, your timeline, your strategy figured out, especially if you have a younger spouse or children that need accounted for. It's never too early to just have a conversation and have a plan of attack. Okay. IRMA, income related monthly adjusted amount. It's a mouthful. It's not Aunt Irma. So in a nutshell here, when you move into Medicare, Medicare is going to coordinate with IRS. So if you are turning 65 in 2025, Medicare and IRS are going to look at your 2023 tax return. Medicare is always looking at your prior 2-year tax return to set your current year Medicare premiums. So in 2025, Medicare is looking at the 2023 tax return. In 2026, Medicare will automatically get your 2024 return information and update your 2026 Medicare premiums. Now, if you are a high earner, you will see this income surcharge because of that high modified AGI. You will see this income surcharge tacked on that given year if the prior 2-year return had a high income, high modified AGI. This year, and this bracket changes every year by about $5,000 or $10,000. So this year, $206,000 for a couple is the first benchmark. So if your 2022 tax return was $206,000 or higher in modified AGI, and you're on Medicare in 2024, you will see an IRMA slapped on that Part B premium. So here, instead of paying $174, you would pay $244 a month if you're in that $206,000 to $258,000 income range. So as you can see, if you're down here on the bottom row, single tax filer making 500 or more, or couple making more than 750,000, then Medicare is quite expensive. This is a per person monthly premium, plus an IRMA on any drug plan if you go standalone Part D or Medicare Advantage, which has the drug built in. You're going to see an IRMA on Part D as well. So just to get in Medicare, for some of you who are high earners, can cost upwards of $670 a month per person. I go back to that initial slide where I was referencing, hey, if you have large group health insurance and you plan to continue working and you're making great money, Medicare may not be advisable because of this IRMA right here. Even though Medicare may have better benefits, better access, less headache, less restriction with that traditional and supplement pathway, it may be way too expensive compared to your heavily subsidized large employer group health plan. And I won't know how to advise you until I get that information. Okay. What Medicare doesn't know, and this is where we come in and assist clients as well, is if you've had a life event like retirement, work reduction, unfortunately, the death of a high earning individual or a divorce, and you're no longer making what you made 2 years ago, Medicare needs to be updated with that life event. And we can tell Medicare that, hey, in 2024, I was working, but in 2025, when I move into Medicare, I'm retired. I'm not going to have 500 grand coming in. I'm going to have 200 grand coming in. You can request this IRMA appeal and tell Medicare, hey, don't use my prior 2-year tax return information. It's stale. Instead, use my current anticipated income based on my retirement. Okay. We help you through this process and we let you know if it's advisable to make an appeal and help you with the paperwork. Where we can't come in, which is totally unfortunate, we can't come in and call Social Security on your behalf to say, hey, did you get Betty's appeal? Where are you in the process? They require the client to be on the phone. And if there's ever an issue where Medicare is giving you a runaround or Social Security rep is just, you've called 5 times and got 5 answers, at that point, we're hopping on the phone call with you after the first attempt, and doing a 3-way call with Social Security. And I will say Social Security and Medicare, if you're out at the Reston office, the Alexandria office, the Charlottesville office, they vary drastically. It all depends on what rep shows up that day and is processing the paperwork, is picking up the phone. You get a lot of variations and differing answers to your questions depending on which office you're calling. So it can be a very frustrating experience for you as the client. So our goal is to help eliminate and kind of guide. Even though we can't take over, we want to help and provide support when Social Security fumbles or Medicare fumbles your paperwork. I just had an experience with that today. That's why I'm saying it. It's fresh on my mind. But anyway, so this Inflation Reduction Act that some of you may have heard about is radically changing the Part D drug market. In years past, we had what was called this donut hole coverage gap exposure under any Medicare drug product. This year and next year, that exposure, that donut hole is being eliminated. In 2025, you will see a $2,000 cap on any drug plan, whether it's Medicare supplement and drug plan pathway, or you opt for the Medicare Advantage pathway with the built-in drug component. You will have a $2,000 cap on your out-of-pocket exposure. So the key here is to find the formulary, the drug plan that has your prescriptions covered on the formulary. So a win with the Inflation Reduction Act is that if you are on very expensive meds, you're on Ozempic, Jardiance, Eliquis, you know, very expensive derm creams or inhalers, Brio. In the past, you would pay $6, $7, $8,000 to move into Medicare and your copays and your co-insurance on your meds. This year, the blessing with the Inflation Reduction Act is that you will see a $2,000 cap. You won't go over $2,000. With that being said, there's a negative that's coming and surfacing because of this regulation. The drug plans are now the responsible payer for anything over $2,000. So to offset their risk, their exposure for anything over $2,000, they are increasing their premiums. They're squeezing the formularies to be more efficient under all of these drug plan products. They're putting more quantity limits, more pre-authorization on your medications, more step therapy, squeezing the pharmacy networks, more so the formulary than the pharmacy. So they're really trying to manage the cost on these drug plans more so than we've seen in the past to offset that $2,000 cap where they're responsible for anything over. So it's good for the consumer who has very expensive meds, but for those who are on cheap generics, you're likely paying more than you ever have before for drug coverage, which is unfortunate, but that's the market that we are playing in right now. So our goal is to provide clarification, clarity, education, and accurate information here when we are shopping the drug plans, and to make sure your prescriptions are covered. There are formulary exceptions if you are on a plan that doesn't cover a one-off, mid-year prescribed plan. We can assist with those formulary exception requests. They're not always approved by the drug plan, but typically when your doctor is advocating for it, you have a pretty solid chance of getting that formulary exception approved. Also new to Inflation Reduction Act in 2025, if you are on a medication that costs over $600 in retail costs, the smoothing provision will allow you to set up a payment program where instead of paying $2,000 right up front, because your medication's a $5,000 med, you come out of pocket in January $2,000. Medicare and the pharmacies and the drug plans are all coordinating to allow you to pay, it's $167 a month in 12 installments instead of coming out of pocket $2,000, which for some people can be unaffordable. So their goal is to avoid having somebody not fill a medication because of that high, sticker shock being and having to meet that $2,000 exposure right at the start of the year. So that's new. I mean, this is all coming out real time. We're still waiting on drug plans to release their official product on October 1st. So this is, coming at us. We're doling it out as we see, and it's news to us, and we're just trying to relay it in English and in clear terms to our clients. We have a presentation on September 30th. If you want more information or you have friends who are on Medicare already, I can relay that over to Jared and Lisa. But it's going to cover a lot of this, plus more. It's more geared towards somebody who's already on Medicare. Anyone who is delaying Medicare because you're going to stay on this large group plan, make sure that that large group health plan is creditable, which means that the drug component under the Medicare or the large employer plan, the drug component is deemed as good or better than what Medicare can provide. And if your plan is creditable and you stay on that large group plan to delay Medicare and now come off when you're ready to retire, you'll need to show proof that the group health plan was creditable. So this $2,000 cap can come in and affect the creditability status of these group health plans. So we're keeping a watchful eye on that. We work with a lot of group brokerages when changes like this unfold to make sure that the group plan stays creditable to help you avoid any Part D penalties. Okay, sorry if I completely confused you even more, but I hope you took a lot away from this presentation. I could talk about this all day. I joke that I was born with a Medicare card. It's all I know. It's all we do here at Steinlage, in addition to the ACA consulting. So if you would like to sit down with myself or a teammate from Omega and myself, we are happy to do Zooms. We are happy to do phone calls, email me anytime. Myself and my team are here to assist. I know, Jared, you've worked with Manny, who's my right-hand man. And many of your clients have sung his praises. So yeah, so start this process early. Don't delay it. Don't let it sit on the back burner until it's the month of, is my recommendation.
Yeah, thanks so much, Margo, for tonight's presentation. Just when I feel like I have my arms around Medicare, they throw more at you with stuff like the Inflation Reduction Act. So we're definitely grateful to know you and your firm as experts in the Medicare space. And I was telling Margo, it's rare that we like 100% review rate for the Steinlage agency. Every time we send a client to them, they give phenomenal feedback from the experience that Margo and her team deliver. So we're excited to have them in our Rolodex, and we look forward to continuing that partnership. So thanks so much. And thank you to everyone for attending. There are some great slides, Margo. Can we make these available to the people that attended tonight?
You bet. I'll send them over as soon as we shut down here. I'll email them over.
Awesome. All right. Well, thanks again, everyone, and we'll be in touch soon. Bye.
Alrighty. Thanks, Jared. Bye-bye.